Good evening. I am Dr. Balasubramanian Tyagarajan. Today, we will discuss the concept of history taking in otology. Otology per se involves examination of patients with problems pertaining to ear. So, we will be focusing today on the exact history taking in the a carefully taken history will avoid lot of problems in diagnostic error at a later date. So it is really worthwhile for a clinician to spend that much of time with the patient to elicit a complete and perfect history. This will also reduce the examination time as well as the number of investigations needed to clinch the exact diagnosis. So, this is the most important aspect and often overlooked aspect in the clinical examination of these patients. So, in this lecture today, we'll be focusing only on the various fine nuances involved in the history taking pertaining to otological patients. So, before starting to question the patient pertaining to a symptom, the physician or the clinician should be seated in front of the patient, and the patient should be seated comfortably. And before occupying the chair, the physician should first introduce himself and address the patient by their name. That is very important because by addressing the patient by his or her name, the error in patient identity or patient being switched is minimized, and the patient feels that much confident that this doctor is addressing me by name. So naturally, if you address somebody by name, it brings out a lot of intimacy between them. So a patient who feels comfortable with the doctor always tends to give out a most accurate history of the various problems involved. So I have been stressing about the importance of history taking, but history taking really ensures a correct diagnosis is made even before the clinical examination is embarked on in a majority of cases. And it also shortens the time spent on the physical examination, and it reassures the patient that this doctor is there to help me. And a physician can identify the various factors that could have caused this problem or aggravated this problem, thereby enabling them to suggest corrective steps to the patient. A good history again will reveal the presence of chronic illnesses and other prior history states which the patient would have been on treatment for the same. And now we are going to focus on a symptom based approach of history taking. These are the 5 cardinal symptoms the patient is going to present with in an otological clinic. It can be a hearing loss, it can be tinnitus, it can be ear discharge, it can be vertigo or giddiness, and then it can be ear pain. So all these 5 aspects of otological complaints or symptoms should be addressed one below the other. And regarding the patient complaint, the patient should be allowed to narrate the complaints, and the clinician should avoid persistent questioning of the patient initially, and he should be a very good listener, but he can be questioned directly if he is dilly-dallying or if he is not coming to the exact point. The patient can be questioned directly for which complaint that he is seeking medical attention for. In fact, majority of these patients can come out with a list of complaints, and if the patient is going to come out with a list of complaints, the chronology of these complaints should be short. If the patient is going to say, I had ear pain, I had ear discharge, I had ear block, the patient should be clearly asked to state which started first, which followed later, because this is a very, very important implication in the accurate diagnosis of the patient. The clinician should be warned that the patients invariably are known to give importance to the most troublesome of their complaint. If the patient is being troubled by ear pain alone, the patient will be focusing only on that complaint and he may not provide adequate details of the other features of the disease. So the physician should be guarded against this type of problems. And now the patient's complaint, when the physician is attempting to document the complaints presented or narrated by the patient, the complaint should be documented in the exact words of the patient. This is very important. And then the patient again should be coaxed to narrate the exact chronology or sequence of these complaints. And the patient should also be questioned pertaining to various aggravating and relieving factors which pertaining to this complaint. And then history of these detailed complaints should be included, and these each and every one of the complaints narrated by the patient should be clearly documented. As far as the chronology is concerned, let us just imagine a scenario wherein the patient is having ear discharge due to acute otitis media. This is again I am narrating as a classic example. So these patients will complain of ear discharge and they may not complain of ear pain, which could have preceded the ear discharge. Since the ear discharge is really troublesome, the patient will keep on narrating the complaint of ear discharge. So this is where a clinician should prudently ask the patient whether this ear discharge was preceded by an episode of pain in the ear. And then again, the patient should also be asked whether he or she had any running nose prior to the episode of pain. So, if on persistent direct questioning, the patient could come out with the history of rhinorrhea, acute rhinorrhea, and then followed by pain in the ear, and then followed by ear discharge. The discharging ear suddenly becomes pain-free. So, these features, if chronology is taken into consideration, will actively point towards the exact diagnosis of acute otitis media. So this is where the chronology really matters, the chronology of the complaints. Now, the next in the list of symptom is going to be the hearing loss. This is actually the most of the patients are bothered actually by the hearing loss. When the patient is complaining of hearing loss or blocked ear, they should be directly asked whether the hearing loss is sudden or hearing loss is progressive. If the hearing loss is sudden, then so many other diagnoses gets into the picture. If the hearing loss is progressive, then you need to think in terms of sensorineural hearing loss due to degeneration of the nerve, due to noise causing problems with the cochlear hair cells. So the exact onset, whether the hearing loss is sudden or progressive, will be a very important pointer towards the diagnosis of what exactly causes the hearing loss. In fact, even wax can cause sudden hearing loss because the patient, while attempting to remove wax, would have inadvertently pushed the wax closer to the eardrum. So such of these patients will suddenly say, I have a sudden hearing loss. And on persistent questioning, then they may confide that the hearing loss was followed by a failed attempt to remove ear wax. Whereas the progressive hearing loss again can happen in the case of sensorineural hearing loss or in the case of aged patients due to presbyacusis because the age-related degeneration of the cochlear outer hair cells. So this is again a very important point which a clinician should bear in mind. Then again, in a patient with diabetes mellitus, again, the hearing loss can be sensorineural nature and also progressive in nature. And then the next comes the exact difficulty in hearing. So this again, some of the patients could volunteer this information, but majority of them don't really volunteer. Supposing this important aspect can be covered by a simple question by the clinician. The clinician can ask, when someone speaks to you, do you really hear the spoken word, or are you not able to comprehend the word? Then the patient will come out saying, I can hear them speak to me, but I'm not able to comprehend what they speak. So this exactly is a pointer towards a diagnosis of sensorineural hearing loss. In sensorineural hearing loss, the patient will be able to perceive the sound, but they may not be able to grasp the meaning of the spoken word. So this is exactly where the speech discrimination capacity of the patient takes a beating, and the patient is unable to comprehend the spoken word. This commonly occurs in presbycusis or age-related hearing loss, or in hearing loss caused due to noise-induced trauma, noise-induced degeneration of the cochlear hair cells. Here, the sensorineural hearing loss will involve the high frequencies, and classically these patients will say that they are not able to comprehend when a female is speaking to them. The basic complaint is they will say, my wife is complaining that I'm not able to, I'm deliberately turning my deaf ear to her. So this means that he is definitely having a sensorineural hearing loss, because females are prone to have a speech frequency which is in the higher range, so that these patients with sensorineural hearing loss may not be able to comprehend the words spoken by their female counterpart. And then the third aspect is the presence or absence of tinnitus should be brought out by direct questioning of the patient. So the examiner should ask whether tinnitus preceded or followed the ear blocks. This again is a very important aspect. If the patient says that tinnitus preceded, a long duration of tinnitus preceded this hearing loss, it goes without saying this is actually a sensorineural hearing loss, or probably due to presbycusis or a noise-induced hearing loss. Whereas if the tinnitus follows ear block, again I repeat, if the tinnitus follows ear block, this could probably be due to the presence of wax. So what happens is, if wax is there in the ear, occluding the external auditory canal, the inner, our body really creates a lot of noise. The alveoli opening, rush of air into the lungs, the flow of blood in the blood vessels, all of these low frequency sounds. Thankfully, these frequent sounds are all low frequency sounds, and these low frequency sounds become augmented, and the patient becomes aware of these low frequency sounds produced by these normal physiological mechanism inside the body in the presence of wax. So this type of tinnitus invariably occurs after the ear block, and this is classically seen in patients with impacted cerumen or ear wax impaction. So by taking an accurate history, invariably we can come to a reasonably accurate diagnosis. Next comes the tinnitus. Tinnitus is nothing but hearing a buzzing sound in the ear. See, whereas when the patient is complaining of tinnitus, you should ask whether what type of tinnitus, whether it is ringing in nature, whether it is roaring in nature, whether it is hissing in nature. Hissing tinnitus invariably happens with the internal milieu sounds produced within the body. And then you can classically ask the duration of the tinnitus, and then you should seek the history of other associated features which go along with tinnitus, like giddiness and vertigo. If the tinnitus is associated with giddiness and vertigo, then invariably you should rule out Meniere's disease. Sorry. So the classic associated features with tinnitus could be giddiness or vertigo. And then the patient should be directly quizzed regarding the various difficulties caused by tinnitus. The patient could have problem with sleeping. They are insomniacs. They are unable to sleep because of this tinnitus. It is worse during night time. Invariably, patient's tinnitus is worse during night time because night is totally calm and the extraneous noise is not there. The tinnitus is not masked, and the patient becomes conscious and aware of this problem. And then a clinician should go that extra yard to rule out the objective cause of tinnitus. I have already narrated one classic objective cause of tinnitus that happens to be the presence of impacted wax, making the patient aware of the normal low frequency noises produced by the normal physiological mechanism inside the body, like blood flow, alveolar opening, all these things. So diligent steps should be taken to rule out objective cause of tinnitus, which includes a patent eustachian tube. The patent eustachian tube can cause a hissing sound. This can also be sensed or heard by the examiner. Then again, a classic case of objective tinnitus happens to be palatal myoclonus. It causes clicking noise in the ear. That is due to contraction of the palatal musculature. So, in the presence of palatal myoclonus, these patients have clicking tinnitus. And then invariably, all these patients should undergo psychological evaluation to rule out psychosis. Psychosis is again another common cause of tinnitus. The next important complaint happens to be the ear discharge. The first thing you should ask the patient is the quantity of the discharge. If the quantity of the discharge is scanty, that should cause alarm, because a scanty discharge is a classic feature of an unsafe ear, a ear which can create problems at a later date. It can cause intracranial complications, it can cause intertemporal complications. All these complications can occur in ears with disorders involving the pars flaccida. In inflammatory disorders involving the pars flaccida, the quantity of discharge is going to be pretty scanty, and quality wise the discharge is going to be pretty foul smelling. So these two features will point towards a diagnosis or towards classifying the patient as having a safe or a unsafe unsafe type of middle ear disorder. So quantity and quality. If the patient complains of profuse discharge, so if the profuse discharge always occurs in tubotympanic type of disorders, whereas in the case of a complaint but saying that I'm having a torrential discharge but does not stop, cotton gets wet, I keep on putting cotton, immediately within 2 minutes the entire cotton I need to change it because it has become too wet. So such is the amount of discharge, then it goes without saying these patients could have an abscess. It can be an extradural abscess following chronic suppurative otitis media. So profuse torrential discharge can be caused due to draining extradural abscess. And then again, the discharge can be mucoid in nature. If the discharge is mucoid in nature, obviously it is coming from the middle ear cavity. If the discharge is clear in nature, if the discharge is watery, then it can be a cerebrospinal fluid otorrhea, CSF otorrhea. So again, the quantity and quality of the discharge is very important. The patient should be clearly questioned pertaining to it. Then associated features along with the discharge, the patient should be directly questioned about whether this discharge was preceded by an episode of pain or discharge was followed by an episode of pain. Invariably, if the discharge is preceded by an episode of pain, it goes without saying it could have happened following acute otitis media. If the discharge is followed by pain, it can be due to associated otitis externa, because patients have a tendency to use earbuds to clear the external aortic canal of the discharge. So using constant use of earbuds traumatizes the tender skin lining of the external aortic canal, causing otitis externa, because already the skin is drenched or found to be in contact with inflammatory material and pus. So using a earbud to clean that area can cause a minor trauma, thereby causing infection of the skin lining of the external aortic canal, causing otitis externa. Then again, discharge associated with deafness. So if the patient is having deafness associated with discharge, it goes without saying a large portion of the eardrum has been ruptured. So a large surface area of the eardrum, if it is damaged, then obviously it will lead to deafness. So in these patients, presence of discharge will improve the hearing, because the discharge, the ear filled with discharge again will conduct sound better, whereas the ear which is free of discharge with a large central perforation, the sound conduction is poor. So these patients, the deafness improves in the presence of discharge, and the deafness deteriorates in the absence of discharge. This is again another classic feature you see in these patients with large perforations involving the eardrum. And Next comes the pain, ear pain, or otherwise technically you can use the term otology to indicate the ear pain. Again, here we should ask about the onset of the pain, associated features, whether the patient has ear discharge along with the pain, or whether the pain preceded or followed the discharge, which I have already been stressing on it. And then you need to ask whether the pain is radiating to the jaw, whether it is radiating to the teeth, or whether it's radiating to the eye. So all these things should be sought. And then referred otology again should be ruled out, because pain in the ear need not be caused by pathology of the ear alone. It can be caused due to tonsillar inflammation, can be caused due to other diseases involving the same dermatome. So, for example, acute tonsillitis again can cause ear pain. Inflammatory lesions involving the nasopharynx again can mimic ear pain. So, referred pain to the ear should be ruled out, because in the presence of, if the patient complains of ear pain, our focus of the clinician, or the focus of the patient and the clinician, is going to be in the ear. But whereas if the pain starts due to conditions involving the other associated area supplied by the same nerve, it can be either nasopharynx or it can be tonsil. Again, these conditions should be ruled out, and referred otology should definitely be ruled out in all patients with pain in the ear. Then personal history, the examiner should dwell some time eliciting personal history pertaining to the habits of the patient. So probably the patient is a smoker. If the patient is known to consume alcohol, the exact quantum of consumption per day again can be quizzed and documented. And the presence of diabetes mellitus and hypertension along with the drug history again will be helpful, because diabetes mellitus is known to cause, I repeat again, diabetes mellitus is known to cause sensory nerve hearing loss and early onset of presbyacusis. So, presence of diabetes mellitus should be sought, presence of hypertension, drug history, and then their work habits, where exactly they work, whether they work in a noisy environment, again, those aspects again will have to be questioned. So I've been telling you about drug history, aspirins, anti-inflammatory drugs are all autotoxic, and then family history should be solicited, and occupational history again should be sought. If the patient is working in a factory where the shop floor is very noisy, again these patients can have noise-induced hearing loss. Thank you so much for your patient listening.